after the hair follicle. And I liken primary scarring alopecia to this picture. Here we have a dog staring at this squirrel. And I assure you, this dog is not looking at the flower basket. It's not looking at the grass. It's not looking at the trees. It's looking directly at this squirrel. That is on this dog's mind. And so in primary scarring alopecia, we have a very similar phenomenon. We can advance the slide. Sorry, Michael, I'm not getting a good advance on these slides. We'll go back. Great. So in primary scarring alopecia, the immune system is going after this hair follicle. That is its great focus. So let's take a look at these. Primary scarring alopecias include FFA and LPP, includes other things like central centrifugal cicatricial alopecia, includes folliculitis decalvans. You may have heard of these. Secondary scarring alopecia includes things like burns and infections, where everything in the skin gets destroyed or affected, not just the hair follicle. So in primary scarring alopecia and secondary scarring alopecia, what we see up close is that the loss of these little follicular openings, these little follicular pores, are gone. We no longer see the openings. It appears very smooth, almost like a skating rink. That's very typical of what we see clinically in scarring alopecia. And when you see a non-scarring alopecia, conditions like alopecia areata or androgenetic alopecia, you see these little follicular openings or these pores, but those are gone in scarring alopecia because they are replaced by fibrotic tissue. So when you look up close, you don't see these pores. This is an up-close image of lichen planopilaris, where these little openings have been destroyed. So the primary scarring alopecia leads to destruction of hair follicles and they get replaced by scar. Our goal, of course, is to intervene so we can stop this process so the body doesn't have a chance to lay down scar. So let's take a look at these conditions. You're very familiar with these conditions. The image on the left is lichen planopilaris. The image on the right is frontal fibrosing alopecia. LPP often affects the central scalp, although other areas can be affected. The scalp is often red. These patients are itchy. They have burning. It's tender. FFA, in contrast, affects the frontal scalp. They may have eyebrow loss, body hair loss, and they may have other areas of the scalp affected as well. Now, FFA is currently thought to be a subtype of LPP. Now, when I think about LPP and FFA, I think about this beautiful image. This is Thailand. And there's a saying in Thailand, same, but different. And if you've been to Thailand, you've heard that saying, I'm sure, at least a few dozen times. It's a very popular expression, same, but different. And it depicts a situation where there's some similarities, but it's kind of different. So people say same, but different. And FFA and LPP is same, but different. So let's take a look at what makes it the same, and let's take a look at what makes it different. So these two conditions are primary scarring alopecias. The immune system is attacking the hair. They have identical findings on biopsy. And so you cannot ask your pathologist to tell you if this is FFA or LPP. That's the job of the clinician. And so they have identical findings. But what has been uncovered now is they have changes in a few signaling pathways deep inside the hair follicles, one called PPAR gamma, and they have loss of immune privilege. We'll take a look at what this means. It's fundamental to understanding. So what happens normally in the scalp? Well, here's a hair follicle. Here we have a hair shaft in orange. And what we have at the top is the so-called oil glands or sebaceous glands. Underneath that, we have these little yellow dots called the stem cells. And the stem cells are so important because if you take one of these yellow dots, you have in your hand the ability to grow a brand new hair. The stem cells are incredibly precious. And the body knows they are precious because the body makes absolutely certain that nothing gets in the way of the stem cells. That if there's any inflammation floating around, the body says, don't go anywhere near these stem cells. And so we call that immune privilege. And immune privilege is a really, really important concept. And so here you can imagine if you have some viruses or bacteria that enter into the body, you have T cells and immune cells that are ready to attack those viruses. And so those T cells and immune cells float all around the bloodstream, and they're ready to attack, attack, attack. And the body makes absolutely certain that those inflammatory immune cells that are floating around don't get anywhere near the hair follicle. This is an immune privileged site. The body is going to do absolutely everything to protect these stem cells. Don't get anywhere near me. And what we see in LPP and FFA is inflammation. And this is depicted here by these little black dots. And this inflammation is in the upper part of the hair follicle around these stem cells. And this inflammation causes these stem cells to start disappearing. And so where we used to have hundreds and hundreds, we now have 50, 40, 30, 20. We have much fewer stem cells. And what hair researchers have found is this whole delicate process of immune privilege is gone. These stop signs are no longer found. That hair follicle is no longer protected. And so it's said that LPP and FFA have a loss of immune privilege. This is a critical system failure. The hair follicle does not want this situation. It is designed to protect itself. But in these inflammatory scarring alopecias, immune privilege is gone. And so in LPP and FFA, we see loss of stem cells, we see loss of the sebaceous glands, and we see loss of immune privilege. And that is found in LPP and FFA and many of these scarring alopecias. So did these little hair follicle stem cells die? Well, the early thinking was that if there's all this inflammation, they must have died. These little yellow dots must have disappeared because they've been attacked by the immune system. And so where there was 15 or 20 little yellow dots in my previous slide, here we have 3. That was the prior thinking, that the other 17 little yellow dots must have died. But what we're coming to understand now in the hair research field is that lo and behold, some of them aren't dying, they're changing. They're changing from yellow dots into blue dots. And those blue dots are fibroblast-like cells or mesenchymal-like cells. These are new types of cells that have different properties. They're not stem cells anymore. They've changed from the yellow dot to the blue dot, and now they make scar tissue. And this is a revolutionary new finding in the field. And you'll see this referred to as epithelial mesenchymal transition. What it means is that the stem cells are putting on a new t-shirt and saying, I'm part of another team now. So why does this all occur? Why do we have loss of immune privilege? Why does someone take away these stop signs? Why do we have loss of the stem cells? Why do we get epithelial mesenchymal transition? Well, some really incredible work started about 2009 by Dr. Carnig and Parity Mirmarani and colleagues, where they looked at biopsies from patients with LPP and compared it to those patients without LPP. And what they found is that the genes controlling lipid metabolism were significantly changed in LPP. And they found that there was an expression or an increased abundance of so-called pro-inflammatory lipids or fats that started to accumulate in the scalp of patients with LPP and FFA. And so it's now come to be understood that you get these pro-inflammatory lipids, and this triggers some of these pathways that lead to the loss of the sebaceous gland, inflammation, loss of immune privilege, and loss of stem cells. And why does this happen? Well, there's many reasons that are now coming to be unfolded, but one of the reasons, which was uncovered very early on, is that there's a reduction in this signaling pathway in hair follicles called PPAR gamma. Normally, hair follicles keep a lot of PPAR gamma signaling around, but for some reason it starts disappearing. And Dr. Karnick and colleagues created a mouse in the laboratory where they could shut off the ability of the mouse to produce PPAR gamma. And what they found is that these mice developed scarring alopecia. And so this was some really wonderful evidence that, wow, this simple signaling pathway seems absolutely critical, that if you don't have PPAR gamma around, you're going to get scarring alopecia. And so in the 2009, 2010, it became to be understood that reduced PPAR gamma causes the scalp to produce all these pro-inflammatory toxic lipids, and this sets up a pathway that leads to loss of sebaceous glands and immune privilege. And so what's the trigger in all this? Why does this occur? Well, we're going to talk about some of the genetics and some of the environmental factors that lead this to occur. But what's come to be appreciated in both LPP and FFA is that there is this reduction in this PPAR gamma pathway. And this causes these yellow dot stem cells to undergo epithelial mesenchymal transition. They decide that, you know what? I need to become a fibroblast-like cell now. That's my new job. This leads to loss of immune privilege, stop signs start disappearing, and this enables the immune system to attack. It just so happens that epithelial mesenchymal transition, or EMT, is more important in FFA, that researchers think, and immune attack is more important slightly in LPP, but both of these are very relevant in both. And so there's this destruction of hair follicles and replacement of scar when this pathway unfolds. Now, there's a remarkable drug that has been studied for a long time, and that's called pioglitazone. And what pioglitazone does is it increases the level of PPAR. It tells hair follicles that don't go about reducing your levels of PPAR gamma, keep them nice and high. And so what pioglitazone does is it blocks this pathway. It blocks the ability of hair follicle stem cells to undergo epithelial mesenchymal transition, and it blocks this loss of immune privilege. And so these are the things that are the same in LPP and FFA. What are the things that are different? Are they truly cousins, or are they more distant than just cousins? Well, there's a lot of difference. LPP is more likely to occur in younger patients slightly. FFA occurs in slightly older individuals. LPP patients are a little more likely to be women, but there's a significant proportion of men. Most patients with FFA are women. In LPP, the mid-scalp and the vertex are often affected in the early stages. In FFA, it's the frontal hairline. You sometimes see eyebrow loss in LPP, but it's not that common. It is very common in FFA, and most people have eyebrow loss, and most people start this journey with eyebrow loss. The skin, the nails, the mouth can be affected. That's not common in FFA. The scalp tends to be more red in LPP. It tends to be less red in FFA. We're coming to understand that LPP, the immune system, targets big terminal hairs on the scalp, whereas in FFA, it targets these tiny, thin, vellus hairs and these miniaturizing hairs. the immune system is actually going after slightly different hairs. Women with FFA often have excess androgens in a third of patients, whereas in FFA, there's an abundance of patients with androgen deficiency. Patients with LPP often have less likelihood of having androgenetic hair loss. This is much more common in FFA. There's some differences in pathology, where in FFA, there's some decrease in pigment producing cells for some reason. LPP numbers finally are pretty constant year after year after year, but FFA is an epidemic. Numbers are going up and up and up. And so is it same, or different? Well, there's a little bit of same, but there's a whole lot of different. I think as we move forward in understanding LPP and FFA, we really need to have that mindset that these are slightly different conditions. Some patients with LPP have FFA, that's true. Some patients with FFA have LPP, that's true. When we look at diseases that are present in these two populations, we see that patients with FFA are more likely to have psoriasis. Patients with LPP are more likely to have lichen planus of the skin. Patients with FFA are more likely to have vitiligo. They're more likely to have early menopause. Patients with LPP are just a little more likely to have another hair loss condition called alopecia areata. But patients with FFA are more likely to have lupus, just slightly. And so is it same, but different? It's a little bit more of the different, but there are similarities. So what's the basic model? Well, I'd like to close by introducing you to this four-step model. First, we have some kind of predisposing factor in a patient with FFA or LPP. They have this predisposing factor. They walk around for many years with these predisposing factors. Many patients never go on to get LPP and FFA. But if there's some triggering factor present, it sets things in motion, it creates inflammation, it creates collapse of the immune privilege, epithelial mesenchymal transition, loss of stem cells, and fibrosis. So what about step one? So what are these predisposing factors? Well, we've talked about PPAR gamma, so there may be some differences in how PPAR gamma is regulated in patients. But there's predisposing factors that includes genes. It's recently been discovered that there's 4 key genes that increase the risk of developing FFA. And this was some absolutely incredible work from the UK and Spain. And sometimes in FFA, there's actually a family history, and 8 to 17% of patients with FFA have a family history. So it's not uncommon. Hormones play a clear role. We've seen in LPP, there's an increase in androgens. In FFA, there's an androgen deficiency. There's some differences in estrogen. We don't fully understand that, but women with FFA are more likely to have early menopause. Women with FFA are more likely to have had oophorectomy or removal of ovaries. And so we know that there is a strong hormonal component. But other factors like hormone replacement therapy seem to have absolutely no role in FFA, which in some ways comes as a surprise. Other triggering factors include viruses, autoimmune conditions, and diets. We don't fully understand all of this yet. What about step two? What about the environmental factors? There's a whole host of things that happen outside of the front door that affect a person's chance to develop FFA. Trauma to the scalp, including facelifts, including hair transplant surgery, increases the chance of developing lichen planopilaris. There's an increased interest now about cosmetics. Are there ingredients in facial moisturizers or sunscreens that increase the chance of FFA, for example? The sunscreen issue seems somewhat controversial and maybe not as important as we once thought, but it continues to be studied. Ultraviolet radiation might be a triggering factor. It's clear in some patients with FFA, that they're more sensitive to the sun. What does this mean? We don't know. There's a real push in the field to understand the role of allergens, especially fragrance allergens. Do patients with LPP and FFA have a greater chance of being allergic to fragrance ingredients in cosmetics, in shampoos, in you name it? Are these creating problems in these patients? We don't know yet. What about stress? Well, stress is something that continues to be studied because stress activates the immune system. It activates a specific type of inflammation called neurogenic inflammation. And so stress is thought to play some kind of a role in many autoimmune conditions, but particularly in these conditions, and perhaps both FFA and LPP. There's certain medications that now are thought to predispose. Some of the antiestrogens like raloxifene, tamoxifen, these increase the risk of FFA by quite a magnitude. And there's a whole list of other medications that are implicated as well. And so what about this inflammation? Well, we used to think that FFA and LPP were all about a lymphocyte, this T cell that floats around in the blood. And if you wanted to talk about LPP and FFA, you should use the word T lymphocyte in a sentence. Now we realize that we've kind of missed the whole story, that there's all these other cells that are absolutely critical. There's dendritic cells, there's mast cells, there's macrophages. And so there's a very much an interest right now to understand mast cells, which are a type of allergy cells. And so many on the conference tonight who have these conditions may have been prescribed various types of antihistamines. Finally, what about this collapse of the immune system, epithelial mesenchymal transition, and fibrosis? Well, we've come to understand that many of these pathways, like reduction in PPAR gamma, sets up for the loss of immune privilege, epithelial mesenchymal transition, and ultimately fibrosis. So FFA and LPP, in conclusion, are types of primary scarring alopecias. The immune system is going after the hair follicle, just like in the slide you saw the dog watching the squirrel. The immune system is thinking about the hair follicle because it's been primed to think about the hair follicle. We've spoken about this loss of immune privilege, the loss of stem cells, and ultimately this little hair follicle tract, which used to house a hair shaft, now is filled with fibrotic material or fibrosis. And so the interest now is to understand each of these 4 steps in order to develop treatments that target each of these 4 steps. And might it be possible someday to understand some of the early risk factors and the genetics and some of the predisposing factors for these conditions and block it from happening in the first place? And so with that, I will conclude. I will turn everything back to Christine, and I'll look forward to answering your questions at the end.
So much, Dr. Donovan. I have always loved that whenever I hear you speak, when I was your patient, when I first started out on my journey, that you made the complex. You took the complex and you made it much easier to understand. And thank you for doing that.
Thank you.
Now, some questions based on what to do again to type them in your into the chat portion of your screen, and then I'd like to forward, and I'd like Shapiro, who is professor of dermatology at the New York University Grossman School of Medicine. I've known Dr. Shapiro since the very, very beginning of my hair loss journey, in that he was the one who diagnosed me standing by a window at a dermatology conference, and he looked at me, he looked at my scalp, and he says, "Oh my goodness, dear, you have FFA, you have what I call a follicular emergency. I went quickly back to my room and looked it up and realized, oh my goodness, this is in fact very serious. And I've always been grateful for Dr. Shapiro for getting me on the right path ever so quickly, because I know a lot of people spend a lot of time wondering what their diagnosis might be. So I was very lucky to know Dr. Shapiro early on. So Dr. Shapiro is well known in hair circles around the world. Is We are very lucky to have him, and like Dr. Donovan, he is now on our medical advisory board, medical and scientific advisory board. Dr. Donovan has moved from that to our board. Dr. Shapiro has served on the board of CAR for many years. And Dr. Shapiro is going to take us now through current and emerging therapies for FFA and LPP. So thank you very much, Dr. Shapiro, for taking time with us today.
Thank you very much. Thanks to CAR for inviting me. Thank you very much for that nice introduction. And I do remember that day very well when we first met and we made that diagnosis. Anyway, what I'm going to do is talk to you more about treatment. How do we treat, what's a practical approach to treating frontal fibrosing alopecia and lichen planopilaris? And I usually present with algorithms. First of all, I would like to present my disclosures. I do have disclosures with various companies, but none of this is really that relevant to this particular talk. My practice is unique. It's that it's restricted to only disorders of the scalp. Okay. Okay, can you hear me? You can hear me now, right? Okay, I'm sorry. Okay. My practice is unique in that I'm a dermatologist, but my practice is only disorders of the hair and scalp. I spend 1 hour per patient, at least. Many times it takes more. And I have a policy. The patient ends the consultation, not I. 35% of my patients have alopecia areata, 30% have cicatricial alopecia, and 35% have pattern hair loss and telogen effluvium. Now, when it comes to frontal fibrosing alopecia, 23%, almost 1 in 4 of my practice is frontal fibrosing alopecia. It's just non-stop now, one after another. We also see a lot of lichen planopilaris as well as other scarring conditions, but frontal fibrosing alopecia seems to be at the top. It truly is an epidemic, as Dr. Donovan said. Now, a lot of what I'm about to describe is already published in journals. The journal with the most impact in dermatology is called the Journal of the American Academy of Dermatology, and we did a 2-part session on primary cicatricial alopecias. We talk about treatment. We go through all of this. If any of you can get copies of this on the internet, it would be great. I always give a copy to our patients of this particular article, and we go through each of the conditions and what we need to do for them. And so it's just something we go through: the lymphocytic conditions, the neutrophilic conditions, all the different kinds of primary cicatricial alopecias. And as Dr. Donovan mentioned, it's not just lymphocytic. There's other things that may be involved as well, but certain things are considered lymphocytic, and LPP, lichen planopilaris, and FFA, frontal fibrosing alopecia, are considered more lymphocytic, but there are other cells as well involved. This is a typical case of what we see for lichen planopilaris. Vertex involvement. This is a 60-year-old female, 5-year history. We do a biopsy, and we prove that it is lichen planopilaris. Now, when we talk about lichen planopilaris, there's classic lichen planopilaris, and then there's, again, frontal fibrosing alopecia, which we've already gone through. Dr. Donovan talked about the differences and the similarities, and we'll talk about treatments about these things. Now, what I use a lot in the office is things that measure. I like to know how well I'm doing with the patient. I like to use trichoscopy. I like to count the number of hairs that are in an area. I like to look at whether there's redness or scaling or inflammation, because that will help gauge my what I'm going to, whether I'm going to increase a certain medication, whether I'm going to decrease certain medication, or even stop medication. There's also a new device that's we're using more and more at NYU. We bought a whole bunch of these. It's artificial intelligence type of thing to count the hairs for us. It used to take 9 minutes, let's say, to do it. Now it can take just 40 seconds to count hairs. This is new technology that counts hairs, and also you can magnify the scalp with this and do trichoscopy as well. So this is a new device that more and more hair physicians are getting in their office that will allow us to actually count hairs, give you a whole spectrum of how many hairs are over 90 microns, how many are 60 to 90, how many are 30 to 60, how many are less than 10 or less than 30. So this gives you a whole new way of a computer with artificial intelligence and machine learning that will quantify how much hair an individual has in a particular target area. You want to know whether they're really losing hair. And you can even give a patient a handout so they can take home and study it. Okay, and patients love getting handouts of their hair. Now, we use trichoscopy and for lichen planopilaris and frontal fibrosing alopecia. This is where we look at the scalp magnified. We can do it tenfold with a dermatoscope, or what I use frequently is photo finder, where we can magnify it 70-fold, and we can see the scaling that around the hair follicle and how much redness is around it. And then on the right, you see fibrotic white dots in lichen planopilaris. So these are kind of clues that will help us deduce whether it's lichen planopilaris or frontal fibrosing alopecia. It's important to do trichoscopy. If the doctor isn't doing trichoscopy, they're missing something. They've got to look with a special where they can use an iPhone and add something to it to magnify it, but you've got to really look closely at the roots of the hair and quantify how much inflammation there is. And then if we're always doing to help prove whether it's lichen planopilaris or frontal fibrosing alopecia, we like to prove it with a biopsy. So sometimes it's very obvious that it's frontal fibrosing alopecia. At the beginning, maybe, 15 years ago, we used to biopsy everybody, but now I'm so used to seeing it, it's a waiting room diagnosis. As the patient approaches me, as I go greet them in the waiting room, I just know what they have. And so we don't necessarily always biopsy frontal fibrosing alopecia, but lichen planopilaris, you probably should biopsy on a regular basis, although sometimes that's quite obvious too. Now, there is a condition called pseudopelade of Brock. Pseudo is like, pelade is alopecia areata, but it's pseudo alopecia areata, which was described by a professor at the Pasteur Institute in Paris, and his name was Brock, and we used to think it was different than lichen planopilaris, but it isn't. It's the same. Okay, lichen planopilaris and pseudopelade of Brock, they're all part of the same spectrum. Now, pseudopelade of Brock may be a little less symptomatic. The vertex is often involved, and there are three patterns. There's a scattered confetti-like lesions, there are large plaques, or there's a combination of the two. I went to the original article that was published in 1895 by Brock, It was in French. Unfortunately, je viens de Montréal, so I know how to speak French, and I went through this article, and it was just like reading what lichen planopilaris is in 1895. And this is another form of lichen planopilaris or pseudopelade. Here we get the confetti-like lesions. This was in a young boy, actually, only around 10 years old. Now, dermoscopy, as I said, is crucial and pivotal in helping make the diagnosis. Look for the hyperkeratosis. The doctor must look for the scale, the flakes, the redness, and also it's nice to get a hair density. That can be quantified at certain hair at target areas to determine whether there's loss of hair. There's not going to be increased number of hair because this is a scarring condition usually. So when it comes to classic lichen planopilaris, I look at the extent of the disease. If there's less than 10%, I will use intralesional triamcinolone acetonide, 10 milligrams per cc once a month. We'll do usually 2 cc's, and then we'll also use tacrolimus topically, clobetasol, and minoxidil. If it's stabilized, great. We continue as necessary. Now, if there's more than 10% scalp involvement or there's no stabilization with the previous treatment, we will then add doxycycline 100 milligrams twice a day or hydroxychloroquine or Plaquenil 200 milligrams twice a day. If there's stabilization, great, taper to lowest dose. If there's no stabilization, add pioglitazone, which has already been discussed, and then also naltrexone, which is an anti-opioid that seems to help these individuals. Also, another one to add that more and more people are using is Zyrtec or some kind of antihistamine because mast cells have been found in these lesions as well. And we look for stabilization. If there isn't, then we have to take out the big guns. In other words, those medications that have more side effects, like mycophenolate mofetil, methotrexate, cyclosporin, low-dose isotretinoin may also help. Even JAK inhibitors like a tofacitinib, we're talking more orally than topically, but that's something else that has been shown to help some individuals. So when it comes to TCM, that's tacrolimus, clobetasol, and minoxidil, and I have them put it on in that order. How do they remember it? Turner's classic movies. That's how they can remember. Put on the tacrolimus first, the clobetasol second, and then the minoxidil. And then, of course, injections are important. For lichen planopilaris, I use a concentration of Kenalog or triamcinolone acetonide, 10 milligrams per cc, and I do 2 cc's, and I go around the lesion. In other words, I'm trying to rescue the hairs. This is a hair emergency, and we must rescue the hairs. So this is basically the outline of the algorithm. And we have to be careful not to do hair transplants on these individuals because when you cut into the skin, as Dr. Donovan mentioned, you can make it worse. Also, I did not mention that if it's rapidly progressive, as some people, you may want to put your patient on oral prednisone as well, usually 40 milligrams a day, tapered by 5 milligrams every week. And then by 8 weeks, they're over. By then, the doxycycline and the hydroxychloroquine will hopefully kick in. Now, what about this low-dose naltrexone? I was one of the first to ever use it on lichen planopilaris. It's been used in inflammatory diseases, in Crohn's disease, in multiple sclerosis, and in the dermatologic setting, naltrexone has been used effectively for patients with severe pruritus. Pruritus means itch. But it seems to be anti-inflammatory, and that's why we use it. The side effects for low-dose naltrexone are generally mild, including vivid dreams, nightmares, headache, and increased anxiety. Now, what about PPAR gamma? Dr. Donovan has already mentioned this, and so we use this a lot too, and we'll use it at 15 to 30 milligrams a day. It's also known as Actos as well. And we've already gone through how it works, so I won't go through that again. And these are papers that we published on the use of naltrexone in individuals, and showed that it worked. We usually use 3 to 4.5 milligrams a day, showed a reduction of symptoms. So the new treatments are pioglitazone, which is not so new anymore. Naltrexone, that is new. And another thing to use is the excimer laser. It's not the lasers that you can buy off the internet. It's a special kind of laser that a doctor has in their office, 308 nanometers. You may want to ask your dermatologist whether he has an excimer laser, and because excimer lasers have some effect on helping the anti-inflammatory response. So that is another option to use. And again, we mentioned also using antihistamines as well. Now, what about the response to pioglitazone? We published this already. 18 out of 25 patients with lichen planopilaris showed benefit, and we already have gone through how it works. So it's something you may want to ask your dermatologist if you're not on it already to try it. However, there is a black box warning on it. It can cause bladder cancer in rodents. No one has ever shown this in humans, and that's why it's still available. But you should be aware of this black box warning. Now, this is a 29-year-old female with a 3-year history of hair loss, as you can see here. These are the classic photographs that we take on everybody who comes in. And it's frontal fibrosing alopecia, and it's more common in postmenopausal women, but 15%, almost 20% of my cases occur in younger menstruating women. It can also occur in men, but very rarely. It usually presents in patients between 55 and 65 years of age, but it can occur, like I said, in younger individuals as well. Loss of eyebrows may be the first sign and may be misdiagnosed as alopecia areata. Facial papules, or papules means bumps, reflect tiny hairs being inflamed by this process. The frontal recession can be measured by the distance between the glabella, which is the area between the eyebrows, and the frontal hairline. So when a patient comes in looking like this, or looking like this, or looking like this, we always like to document, take pictures, and these are the papules that we usually see. Now, this is a study that we looked at, a medical review for frontal fibrosing alopecia, which was published in the Journal of the American Academy of Dermatology, and we go through the different treatments that have been used with success. We looked at the literature on 270 items. This was in 2018. The paper was published in 2019. Only treatment regimens where outcomes were considered, we looked at. The majority were case reports or retrospective studies, and the response to therapy was assessed by reported ability to slow or arrest hair loss. Intralesional steroids, that is injecting like we just did, like we talked about for lichen planopilaris, is something that we do. 5-alpha reductase inhibitors, as Dr. Donovan mentioned, may also help these individuals. There's finasteride, or there's dutasteride, which has a longer half-life, and I tend to avoid in women of childbearing age. You have to be careful with these 5-alpha reductase inhibitors because they are teratogenic, and you must make sure that if somebody is on finasteride, that they stop it at least 1 month before they conceive. And I don't like to give dutasteride to women of childbearing age, because the half-life is so long, it stays in the system so long. So 88% in these papers, they show success with intralesional steroids, also with 5-alpha reductase inhibitors. Oral prednisone was rarely used. Other therapies, topical steroids, antibiotics, pioglitazone, systemic retinoids, and hair transplantation is a potential option. This is a paper we published many years ago when I was in Vancouver. We looked at 62 patients and went through all the characteristics of these individuals. And here was another paper that we published when I moved to NYU. This was 92 cases that we looked at. And eyebrow involvement, 96%. Symptoms, burning, itch, hurt, 14%. Other autoimmune disease, 11%. We looked at 92 cases, only 2 men, and 90 were women. Now, what we showed, and I show this to almost every patient, disease stabilization, the percentage we were able to help was 70%. We can't help everybody. Sometimes it doesn't work, whatever we give them. Or sometimes it's too risky to put someone on cyclosporin or whatever. So it's the time to stabilization to finally get this under control is usually around 10 months. And I like to show that to patients. So how do I measure FFA? We use a special ruler that we can then go right onto the scalp, and we measure from glabella to hairline, right out of acanthus to hairline, and we do the sideburns as well. And I do that on every patient every time they come in, and so patients want to know, did their hairline go back? What's happening? And so it's important to do these kinds of measurements. So this again is the typical frontal fibrosing alopecia. If it's rapidly progressive, use oral prednisone. Slowly progressive, then if it's less than 1 centimeter recession, use your tacrolimus clobetasol minoxidil, use your intralesional injections. If there's no improvement, then go over to the other side, okay, where hairline recession is more than 1 centimeter, use your tacrolimus clobetasol minoxidil, do your injections, and you may want to also use a 5-alpha reductase inhibitor. Warning, if a patient has a history of breast cancer, I would not give them a 5-alpha reductase inhibitor. I would stick more to the top 2, okay, and then maybe initiate hydroxychloroquine, which is another option if that box doesn't work. Doxycycline, 100 milligrams twice a day, pioglitazone, 15 milligrams a day, naltrexone, 3 milligrams a day. So we tried in this stepwise fashion. Other options, which are more, they have more side effects, is mycophenolate mofetil, methotrexate, cyclosporin, oral retinoid, or the laser, the 308 nanometer laser, not the ones you can get over the internet. So again, TCM is what we use, and the injection is not 10 milligrams per cc, but only 2.5 milligrams per cc, because we're too close to the face, and you can get atrophy. So this is how we inject. This is how deep we go, and we usually give 30 injections from ear to ear. Okay, and if somebody has lichen planopilaris, in addition to this, we'll also give them injections of 10 milligrams per cc to the top of their head. This is an article we already described, frontal fibrosing alopecia in males, so it does definitely occur in males, and the treatments are basically the same. We identified 7 males, and improvement was observed in 100%. The mean time for visible improvement was 3.8 months. And we basically treat it as we do female FFA. So this again basically tells you how we treat it, and again, try to avoid any kind of injury to the scalp, like a facelift or anything. I tell people forget about brow lifts or anything like that, because that can make it worse. And there are reports of this occurring after a brow lift. What about sunscreens? Dr. Donovan mentioned it was very popular at one point. The jury's not out yet, but there are papers from England that show there may be something in sunscreens. This is another paper as well. And the ultraviolet filters and hair care products, again, possible link with frontal fibrosing alopecia and lichen planopilaris. We even published something in the British Journal of Dermatology, and we questioned the use of chemical sunscreens such as oxybenzone and avobenzone, which were introduced by the FDA in 1988. First cases of FFA were reported in 1994, just 6 years after the FDA approved these chemical sunscreens. And these chemical sunscreens also can affect the coral reef. They have all sorts of issues with them as well. Now, whether they actually cause or are a trigger, we don't really know. But I like my patients to use mineral sunscreens like zinc oxide, Titanium dioxide is also something we like to use, although people have talked about nanoparticles being in titanium dioxide that might have something to do with it. But I want a mineral sunscreen being used on the face of my patients. And just want to say there are people who disagree. John McGrath is a very well-known dermatologist and scientist who feels there is no association with sunscreens that are not only in sunscreens but also just moisturizers. And then there's another paper published by another well-known dermatologist, Henry Lim and Amy McMichael, who say, well, we don't really know. So, we don't really know, but I feel it's better just avoid it because of the time factor. Something's introduced on the market in 1988, then in 1994, people are starting to get this. There's also a genome-wide study looking at, whether it's genetic or not. There are people who've looked at this, and there may be a component of that. And I myself have seen mother-daughter. I've seen sisters with it. I've seen even mother-son with it. Okay, so there's a genetic component to it as well. What about hair transplants? This was published by one of my former fellows, Lisa Chan from Taiwan. And she looked at, how long you should wait till you do a hair transplant. And she waited 5 years and she had no problem. So you possibly can do a hair transplant on these people, but always warn them that it may get worse. And they're taking a big risk by doing a hair transplant. And it shouldn't be active for at least 2 years. And she waited 5 years. And I'm just going to show you a case that we did where we did surgery. We chose an area just in front of the ear. We took around 50 grafts and put it in that area. They survived. She had not been active for 5 years, by the way. Okay, and then you can see before and after, she did regrow some hair. It's not as robust as one would expect, but she was quite happy with that. And then you can see the hair regrowth here. So it is something one might consider, but it's risky, okay? Because you could make the whole process come back again. And here you can see, and she wanted another session. And I said, no, this is enough. I'm scared the second session is going to trigger something and you'll lose all from the first session. I've seen that before in another patient who came to me after they had a session from somebody else. And then had a second session, they lost everything from the first session. So this is a trichologic emergency. Early intervention is important. Ensure diagnosis with a biopsy. Trichoscopy is crucial in following up progress. Adjunctive agents or procedures can improve cosmesis, like putting on powders on the scalp, like Topic, or one of those things that help camouflage this problem. Topical minoxidil 5% solution or foam can help thicken up the hairs around the scarring process. And hair transplantation is something you might want to consider, but I wouldn't rush into it at all because you may make it worse. I'd like to thank our NYU hair team that helped me with all of these studies, and without them, I really couldn't do anything. And there's one individual here I want to thank, Kristen Losico, who's my right hand at NYU, helps me very much for this, for as part of our NYU team. And thank you from the NYU School of Medicine. Thank you.
Thank you very much, Dr. Shapiro, for that great overview of how a good practice takes on the challenge of FFA and LPP. So I know that we have a number of questions in the queue, and I think they're going to flash up in front of us. So what do you know about the relationship between FFA and hyperpigmentation of the face associated with lichen planus, and how it needs to be treated in persons of color? I'm going to throw this one to you, Dr. Donovan, and we'll probably come forward depending on the question.
So pigmentation of the face is very common in individuals of African, Caribbean, and African American descent. This is called lichen planus pigmentosis. And it's actually a sign in many ways that there's some degree of photosensitivity or sensitivity to the sun that might be present. And in many patients, it's present before the condition actually starts. So it's very common and something to look for in cases that are more challenging and you're not sure it is FFA or not. But it is common, and treatment algorithms are, somewhat the same. But we not only treat the hairline in these conditions and the eyebrows, but there may be treatments that will help the lichen planus pigmentosus, which, for people that aren't aware, just refers to some darker color on the face, which is thought to be a very closely related phenomenon to the inflammation occurring in the hair follicles. And so it is something we see commonly.
Okay, thank you very much. Are there any best shampoos, and are there any active ingredients that are good for relieving scalp itch? Dr. Shapiro.
Well, when it comes to relieving itch and shampoos, I mean, you want something that is going to be anti-inflammatory to some extent. So there are various shampoos that contain clobetasol or or other corticosteroid ingredients. So I like to use some of those shampoos. I don't think the shampoos are so critical for the to get rid of the itch. It's more the systemic therapies that we give. The doxycycline or the hydroxychloroquine. The shampoos may help somewhat, but it's not a big factor. Nizoral shampoo or ketoconazole 2% shampoo, which is a prescription in the States. 1% is not a prescription in the States. And we can use that as well. That may help a little bit as well. So those are the shampoos that I tell people to use for this active inflammatory condition. But I don't think the shampoos are crucial in helping these individuals.
All right, thank you. Dr. Donovan, do you have to add to that?
No, I think I don't.
Okay. So is there any new research on tofacitinib, you guys can probably pronounce that better than I can, cream to help reduce the inflammation? Dr. Shapiro.
There are some reports that topical tofacitinib as well as oral tofacitinib may help lichen planopilaris. This was pioneered by Leslie Bordone and Angela Cristiano at Columbia University. And I think that there may be a place for it. I've used it myself on patients. I've used tofacitinib. Another name for it is Xeljanz. And it's quite hard to get in the United States at a reasonable price, but there are ways to get it. Sometimes we have to get it through Canada as well to at a reasonable price. But anyway, in terms of it does help some people. I haven't had great success with topical tofacitinib or even the oral. It hasn't helped that much in my limited amount of experience using it on scarring alopecia. I use a lot of it in alopecia areata, and it really works well there. That's a game changer.
Dr. Donovan, do you have anything to add or any different experience?
The thing that people should be aware of if they're from other countries is that if you go and speak to your pharmacist about topical tofacitinib and how they can make it up in a cream, you will get an astronomical variation in prices. You can ask a pharmacy down the street and they'll quote you $6,000 for a tube. You can ask another one and they'll quote you $600. And so it really depends on the source, how they're making it up. And the way they make it up down the street is going to be different than the way they make it up the street. And so there's still a lot we need to do to figure out how to make this up consistently.
Wow.
I would say most dermatologists in the US are getting it from a pharmacy in Philadelphia called Chemistry RX. And they seem to know how to make it better than most. So I usually order it from them, and they will send it to the person. They don't have to go to Philadelphia to get it.
Oh, that's good. Okay, thank you very much. Next question. Should we all be on, I'm not going to pronounce it, Pigliotti, oh, I'm going to, no, I'm going to try. How long should you use it for? Dr. Shapiro.
Okay. Okay. I use it for a long time in some people. I see if it works, whether it really helps. If it doesn't, I'll stop it. But I have used it, but that we always are very cognizant of the bladder issues and all that, even though it's only in animals. But I have people on it for many, many years. I don't think everybody needs to be on it. I presented an algorithm. The algorithm goes through stepwise when to start it. Things that are more effective, like hydroxychloroquine or doxycycline, should be first-line systemic agents, or 5-alpha reductase inhibitors should be the ones that are the first line, the go-to, not necessarily pioglitazone.
Okay, thanks. Anything to add, Dr. Donovan?
I think that I agree with what Dr. Shapiro said, that certainly pioglitazone is not the first step in my practice, and not everybody should be on it. Every drug has side effects, and we have to think about the safety, the affordability, the feasibility, and the effectiveness of every medication. And we do have to respect that black box warning. It will be terrifying for many patients when they read the label, if they do read the package insert. My patients do. But no, everybody should absolutely not be on pioglitazone. So that's an easy one in that sense.
Okay, thanks. Can you speak about Plaquenil to treat LPP? Are the risks significant and are they worth it, Dr. Donovan?
I think as Dr. Shapiro pointed out in the algorithm, Plaquenil is a very important treatment to consider in lichen planopilaris. It isn't for everyone, but it has been around an awfully long time. It has been studied extensively in a variety of autoimmune diseases, and so we have, hundreds of thousands of patients with rheumatoid arthritis, lupus, and other autoimmune diseases that have been on Plaquenil. Its safety is relatively good. It does have a side effect of eye toxicity, and it harms the retina, but those risks start to increase more significantly after 7, 8, 9, 10 years. And so, of the treatments that we have, when we're trying to balance how good it is with the risks, it comes out quite high in terms of the effectiveness, balancing the risks. And so, I do think it's a really important treatment for patients with LPP to discuss with their provider. Absolutely.
And that makes it a first line treatment. Is that right, Dr. Shapiro?
Definitely.
Well, yeah, it definitely is something you want to try. As I pointed out in my box, in the box in the algorithm, I use a lot of 5-alpha reductase inhibitors, and sometimes I'm talking about FFA, and sometimes that does the trick. But Plaquenil is a very important medication as well to use, and the harm on the eye, it's very, very rare. In the United States, patients are told to go to the ophthalmologist every 6 months. In Canada, it was once a year or once every 2 years. Okay, depends. Okay, but in the US, we tell them they need to go every 6 months and get their eyes, get the retina checked. Another thing about Plaquenil that I didn't mention, one of the side effects is hyperpigmentation of the cheeks, and people can confuse that with they'll think it's part of lichen planus dyspigmentosis, as we already discussed. But you can get dark skin just from Plaquenil too.
And does that go away after you've discontinued Plaquenil use?
Not always.
No, I think I've got that. Okay, thanks. So someone here has permanently lost lots of hair along the hairline. I think that's probably many of us, but not yet enough that it's very noticeable. What are my chances that this disease will eventually burn itself out? The burn itself out question. Dr. Donovan, let's.
Yeah, I think the concept of will the disease burn out depends, in my opinion, on whether we're talking about whether the patient has received treatment or not. Some of the early textbooks and journal articles in FFA stated as the last sentence, it will burn out eventually. I don't think we really know that with great confidence, and a lot of patients don't burn out that easily. And by burnout, we mean you can stop all treatments and the disease just stays the same without getting worse. I don't think we can be quite so confident that the disease burns out so easily, and so we need very watchful and cautious observation. If a patient comes back in 6 months and says, there's been no change in my hairline, my feeling is this is fantastic, but I want to know what it looks like in another year or another 3 years, because often we're surprised that it's budged just a little bit. And so it's very diligent and cautious observation. But certainly there are some burnout, but I don't think it's as common as we like to believe.
I
Okay.
agree. It's not as common. There are people who do burn out, but there are some we think it burns out, and then all of a sudden it starts coming back again. So it's unpredictable to some extent. But I've had some cases that after just 4 months of treatment, and we gradually taper over time, and they were fine, and it has not recurred. It's important that they get monitored, that we look with the trichoscopy and make sure that it's not active, and do all the appropriate things to help monitor that it's not coming back.
I think that as a patient, I think that's one of those things that we're always hoping for, that maybe we'll be one of the lucky ones where it does burn out. But it does seem like it's a gift too good to be true. Um, okay, so someone's being currently treated with PRP, platelet-rich plasma injections to encourage growth from hair follicles not already scarred by FFA. Treatments are working very well. I'm risking increased, more severe FFA flare-ups am I uh, risking more by undergoing these treatments? Dr. Shapiro.
Okay, we just published something because we were interested if PRP actually made things worse. Okay, we thought there might be some Kevnerization. We looked at a small group of patients, and we showed that it did not make people worse. So I don't think that the FFA is getting worse, would get worse from PRP. However, does it really make a difference in making anybody better? I've tried it on patients. I have not had great success with PRP on cicatricial alopecia. Other people have, but PRP is, I use it more for androgenetic alopecia all the time. Okay, and maybe some cases of alopecia areata combined with intralesional cortisones or something will use it. But for cicatricial alopecias, I'm not sure it really works that well. But in this individual, she said she got better, but it's hard to, it needs to be measured and looked at closely. But I can tell her with confidence that it won't make her worse.
Okay. Dr. Donovan, anything to add there?
I think it's really nice that Dr. Shapiro did that study. It gives us the confidence that, we're probably not going to make it worse. But, I'm not a great fan of PRP for scarring alopecia, and we've used it in a large number of patients over the years. And, if a patient, decides together that is a plan they want to take, great. But it usually in most patients doesn't stand up to the standard treatments like the 5-alpha reductase inhibitors, finasteride, dutasteride, steroid injections, isotretinoin. PRP is in a whole different league. And so I want patients to know that there's a tier of great treatments, mediocre treatments, maybe treatments, and we're not sure treatments. And we need to be thinking that all the time.
So do we know, is there anyone doing any research on PRP and cicatricial alopecias? Is there anyone doing an efficacy study? Are you aware of anyone? No,
Well, I did.
doctors?
I can't remember how many patients. It was under 10, and it did not help anybody, but it didn't make him worse. But that was a small study.
Okay, thanks. Okay, this question is there a list of medications that can contribute to FFA? Now, I'm wondering if the question is that would make FFA worse or that starts FFA, if that's what the meaning of the question is, or that I think Dr. Spears already covered the medications that are currently being used to address FFA. So maybe it's the question is around, uh, is there anything that could potentially cause or trigger FFA? And Dr. Shapiro, maybe could you address that question first, or
Well,
does it?
okay, I'm not aware of a medication that would cause frontal fibrosis alopecia or lichen planopilaris. So however, there are some chemotherapy agents like busulfan or one of these. They can cause scarring, hair loss. It's chemotherapy. So, but that's rare that somebody would go on that. And that's chemotherapy for some kind of cancer.
Okay, thanks. Dr. Donovan?
The only ones you'd have to be, cautious of would be tamoxifen and raloxifene, which are the estrogen receptor blockers. So they block estrogen signaling in breast cancer patients. They have a link proposed to them, but other medications are not very common.
Okay, thanks. I hope that addresses the question. Dr. Donovan, can you address metals, the metals that I guess you referred to in step 2?
Yeah, and the concern is that do any of these metals get down in the hair follicle and get trapped? And it's still an area that is not well understood, but there are a few individuals who are wondering about metals like titanium. Do they have any role in the nanoparticles, as Dr. Shapiro mentioned? And so there is some metals that can activate the immune system, and so they are subjects of study. But we don't have great evidence to believe these are culprits. But it's the nanoparticles that are super small that get trapped in hairs and can change the constituent of the hair follicle, so that the immune system wants to come in and patrol what's gone on. That's why the metals was in that diagram.
Okay, thanks. So I've just learned that we have a ton of questions in the queue. So we're going to kind of go at this a little bit rapid fire. So I'm going to give a question to each of you as we go along. So with LPP, are there any indicators for how quickly or severely someone's hair loss will progress over time? Dr. Shapiro.
Well, I mean, we do the initial examination, we do pull tests, we see how much they're actually losing. Always ask a patient if they've shampooed that particular day. And that will help us. Also, trichoscopy will also tell us how aggressive it is as well. But all these things are possible predictors of how well or how fast this will progress.
Thank you. Does PRP therapy do any good for LPP? So I think we talked about FFA. Dr. Donovan, I think you can give probably a quick answer to this one.
I think the answer is the same, and that is that probably doesn't cause harm, but I don't think there's great evidence yet, and so be cautious and have a good plan to monitor pictures, monitor progress, and if it's not working, it's not working, and give it up. But if it's working, great, continue.
Okay, thanks. Can you explain PPAR gamma? This person has FFA. How can he or she increase PPAR? Are there foods, vitamins, etc.? Dr. Shapiro.
I'm not sure aware about the diet helping. I would control. You want the PPAR gamma to be an agonist. You want to increase it, so that's how the pioglitazone works. But I'm not sure of any dietary things you can take that's going to help.
Okay, thanks. Any recommendation for allergy meds that were referred to, type and dose? I think Dr. Donovan, you had spoken about that, right?
We don't have any great evidence that any of them are all that different. Some of the best studied includes cetirizine, which goes by a bunch of different names like Reactine and Zyrtec. There's been some very good studies with cetirizine, but certainly we use a number of them, Blexten and loratadine and many antihistamines, and so fexofenadine or Allegra. And so we don't really yet have any good evidence that any of them are any better than the other. It needs to be studied, but the key concept is that by blocking antihistamines, by blocking histamine signaling, we do good. And so cetirizine is probably the best studied in LPP so far.
Thank you. Okay, we apparently have about 40 questions still in the queue. So what's the latest on Otezla for this condition? Dr. Shapiro.
I have not used it in this condition, so I can't really say that it's a great thing to use. Otezla is made for other conditions, not so much cicatricial alopecias. So I'm not sure how well it works. I'm not going to say yes or no.
Okay, because I do know that some dermatologists are using it. Dr. Donovan, do you have? I am going to actually go to you. Do you have a differing view on this?
We use Otezla in our practice. If you look in the medical journals, there's one study, very poorly conducted study, which showed it probably didn't work all that well. But the internet is absolutely fanatic about Otezla. And so it is something that dermatologists around North America are being presented with often. And so it does seem to help some patients. It is incredibly expensive. And so the question I always have is if I could control the lichen planopilaris with, doxycycline or hydroxychloroquine, which is, 400 to 500 or $700 a year in Canada, versus Primilast or Tesla, which is 15, 18, 19,000. I think I'm going to go with the doxycycline or the hydroxychloroquine. So it probably does something in my experience. How well it works compared to the others, we don't yet know yet, but patients love Otezla.
Okay, thank
I
you.
have tried it, and it did not work on some really bad cases of lichen planopilaris. It just didn't. Okay, but in different hands, different results. I don't know.
Okay, thank you. Is Arimidex on the list of medications? And what about medications for bone density? Dr. Donovan.
We don't have any evidence Arimidex can affect these two scarring alopecias. Certainly, Arimidex can increase the production of androgens in the scalp, which can sometimes worsen androgenetic hair loss in some patients. But it's not thought to be much of a culprit in LPP or FFA. And so, not something that we usually find as a culprit.
Okay, thank you. Next question.
Okay.
Is there, did you have something that you wanted to add there?
Well, I'm just saying, if somebody needs Arimidex because they've had breast cancer, certainly don't want to get them off of it. Or I mean, the most important thing is to treat the breast cancer, okay, and make sure they're on it for whatever 5+ years. I don't want to endanger anyone by stopping something that's important for as part of their therapy for breast cancer.
Okay, thank you. Is there evidence using N-acetylcysteine in the treatment in LPP is beneficial, I guess is the rest of that question. Dr. Shapiro.
No, it's used for trichotillomania, and I use it, and it really works. Trichotillomania is obsessive compulsive behavior, pulling at one's hair. Okay, and I've used it with great success for that kind of thing, but I'm not aware that would help this kind of situation.
Okay, thank you. Does PPR gamma deficiency cause EMT or IP loss first? Is it sort of chicken or egg? Knowing this will reverse which medicine is used first or simultaneously. Dr. Donovan.
Yeah, it's a great question. And we think that the PPAR gamma deficiency sets up the scenario where you get EMT or epithelial mesenchymal transition and loss of immune privilege. It's a great question because we don't know all of the answers in terms of the exact chronology, but it appears that the PPAR gamma reduction comes first very early in the course of this disease when the patient doesn't think anything's wrong. This is happening. And then they go on to develop inflammation and scarring. A patient can have reduction in PPAR gamma years and years before they even have any idea they're about to get lichen planopilaris. And the inflammation comes much later. And so probably it's an early step.
Okay, thank you. Can you elaborate on how diet impacts FFA? And I'm going to give that back to you, Dr. Donovan, because you spoke about that.
Yeah, we don't know with great detail. There has been some studies looking at, some dietary factors like millet seeds and groats, and do these impact? We really don't know yet. I think we are about to bud on the era of anti-inflammatory diets and ingredients that really have an impact on inflammatory conditions. That data is coming out, but I don't think we have it yet for these conditions. And so I think that just adopting as healthy diet as one considers healthy is the way to go. But we don't have good evidence yet.
Okay, thank you. Does Medicare pay for treatment? Dr. Shapiro, because I think this is a U.S. question.
It depends who you go to. Okay, certain doctors take Medicare and will pay for this, and other, they may take other insurance carriers as well. There's so many in the United States. I mean, I practiced in Canada where it was, where the government paid for almost everything for most physicians. Okay, things are changing, of course, but I'm saying in the United States, Medicare, certain doctors take Medicare, certain don't. And so it depends who you go to.
Okay, thanks. Is rosacea common in FFA patients? Dr. Donovan.
Rosacea is very common in FFA, and so I think as part of the screening examination for looking at the scalp, looking at eyebrows, looking at facial papules, I think we have to address the rosacea. And what's not yet clear is whether it's the exact same rosacea as everyone has with classic rosacea, but treatments like doxycycline may be very helpful in these patients, but it's extremely common in FFA, and so we need to be aware of that.
Thank you. Okay. FPHL mimic LPP if biopsy revealed decreased number of follicles, fibrous tracts, and patchy lymphocytic, I can read that, infiltrate. My hair loss started 20 years ago, and I've been asymptomatic except for noticing a slight pinkish tinge at the crown area. Treated with topical and injected steroids. Dr. Shapiro.
Okay, there is an entity called fibrosing alopecia of a pattern distribution, which mimics androgenetic hair loss, and they look the same. It's lichen planopilaris that looks like female pattern hair loss, and you got to treat it appropriately. The biopsy shows scarring, then you treat it as a scarring hair loss problem. If it shows the appropriate lymphocytic type of infiltrate or whatever, then you treat it as such, and you injections. This person is getting injections and all this. So I think that yes, they can mimic. In other words, lichen planopilaris can look just like female pattern hair loss in some people, and it's called fibrosing alopecia of a pattern distribution, or FAPD, and it definitely is well described as a few decades ago, and it can fool people. It can fool people to think that it's just androgenetic hair loss when there's more scarring involved. And a hair transplant would be a total disaster on someone like this.
Okay, thank you. I'm allergic to hydroxychloroquine and nearly every antibiotic I've ever had. So, an allergist specializing in antibiotic allergies has said that doxycycline would be the last resort for me. Steroids and creams don't seem to be helping after 2 years. What is the next thing to try? Dr. Donovan?
Yeah, so a question like this really needs a lot more information from the patient, but there are options for antihistamines like cetirizine we spoke about. There's options for pioglitazone that Dr. Shapiro spoke about. And there's options for mycophenolate mofetil or Cellcept, Myfortic, which is another immunosuppressant. The thing about lichen planopilaris is there are about 18 to 20 treatments. And as Dr. Shapiro pointed out, there's a very logical, algorithmic approach to thinking about this. And so if someone's allergic to antibiotics and hydroxychloroquine, there's still another 16 treatments on the list. So I would not be discouraged. There's quite a few options still waiting. And if you go down that list, you're likely to find something that actually stops the immune system in many cases.
All right. Thank you. So we have another 30 questions. So we're going to do a lightning round here. Short answers, gentlemen. Is naltrexone useful in progressive FFA? Dr. Shapiro.
Yes, yes.
Thank you. Okay. Next question. Are in-home lasers useless? Dr. Donovan.
Not useless, limited use, but there's some data that they reduce inflammation in these scarring alopecias.
Thank you. What about if you're told you are stable? Is it safe to decrease your dose of hydroxychloroquine? Dr. Shapiro.
Yes.
Okay. Oh, you're taking this lightning round seriously. Good. Which medication should you try first for LPP? Dr. Donovan.
If it's very limited, topical steroid injections. If it's more advanced, add on doxycycline or hydroxychloroquine.
Okay, thank you. What is the limit of eczema laser treatments? How many treatments or years of treatment is safe? How long can we do eczema laser without doing damage? Dr. Shapiro.
That has to be addressed by a laser doctor. I don't actually have the laser. I send it to somebody at NYU who does the laser treatments. So, I mean, it can easily be done for a year, but I can't say how long it is. I'm not a laser expert, but it is a fairly safe laser, but I'm not sure of the limits.
And Dr. Donovan, do you know the limit?
I don't. I
I'm
refer
guessing
out
no.
as well.
Okay, thank you. Are there any thoughts in formulating an injectable form of tofacitinib to inject into the scalp?
Well, I would love to do a study, but to do a study requires a lot of steps. I think it's a nice thing to think about, but I mean, you have to go through ethics review board and go through all sorts of hurdles before you can do a study like that.
Yeah, yeah. Okay, thank you. Insurance refused to pay. Oh, what are feelings about minoxidil versus nanoxidil, Dr. Donovan?
So my feeling is if you're going to consider using this treatment, which has been around since 1982, use the treatment that's been around since 1982 first. There are other formulations that I'm okay with my patients trying, but we have reams and reams of good data on minoxidil, and I'd rather my patients start there first, but I'm open to other suggestions afterwards if that doesn't work.
Okay, thanks.
And then the only thing about the nanoxidil preparation is it does not cause facial hypertrichosis, nor is it irritating because there's no propylene glycol, but nor is the minoxidil foam. But I'm just saying there's some advantages to the nanoxidil as well, in that the facial hypertrichosis doesn't seem to occur with the nanoxidil.
Okay. Why is it so difficult to find a dermatologist that specializes in LP and FFA? Many dermatologists don't seem to take this condition seriously. No measurements, no pictures. I'm going to go to Shapiro, Dr. Shapiro on this.
Well, it takes a long time to go through a patient like this. As I said, I spend an hour with every patient. And so, and sometimes an hour and a half. An FFA is an hour and a half, practically. It's a devastating condition. And so you have to spend a lot of time with the patient. Most dermatologists are not set up in their offices to see a patient for an hour and a half. Okay, many are general dermatologists and they have to see so many patients per hour in order to pay their overhead. So you can't blame them for having to go through it quickly. But if you're set up like Dr. Donovan set up, I'm set up to take a long time with these patients, so they feel they're getting all the attention, the pictures, and everything, because we've kind of made this our practice, our life's work, and so we spend an hour plus with every patient.
Okay, thank you. I know Dr. Donovan does the same thing. So, and many of the hair specialists that are on the CARF board and our scientific and medical advisory board. Dr. Shapiro, are you accepting new patients?
Yes,
Excuse me. And how long is
yes.
the wait list?
It's around a month, 6 weeks.
Okay. How often should the injections be given, Dr. Donovan?
So it really depends on the patient, but certainly performing injections initially for LPP and FFA, and then deciding what is it that you're going to measure. If a patient's going to come back in 2 months or 3 months, we want to measure, is it reducing the scaling or the inflammation, or is it stopping the hair loss? If there's no evidence that it's doing anything positive, then the answer is probably we stop. But if the injections are helping and it's not causing indentations or atrophy, then this is a really helpful treatment for FFA and lichen planopilaris. And so I may continue every 8 to 12 weeks, depending on the patient, for quite an ongoing amount of time. But it really depends on careful monitoring each visit. Is this actually doing anything? And I don't want my patient to get into a routine that every 2 or 3 months they just come in for injections, injections, injections. We need to be thinking about what it's doing and what it's not doing, and be thinking about when is the time to stop.
All right, thank you. Dr. Shapiro, should FFA patients not use microblading or something similar to restore their eyebrows?
I'm all for microblading. I think it's a good thing. Okay, especially as many of these women are older. Okay, and as they age, their hands shake, their vision may not be as good. It's hard to pencil in an eyebrow. If you're 85 and and shaking, can't see that well. The microblading is perfect for somebody like that. It doesn't make the condition worse. I've never seen it make it worse.
And I have to say, as someone who doesn't yet have shaky hands, having microbladed eyebrows has made all the difference to being able to just live my life. Um, okay, so how do people manage the powdery residue left by tacrolimus? Someone has LPP, prefers to wash my hair every 2 to 3 days because she loses so much hair every time she washes it, and her scalp is so dry. So, what's the answer? Um,
I
Dr.
use a lot
Shapiro.
of topical tacrolimus. So, um, you know, sometimes if you change the vehicle, it may make it a little bit better. Sometimes people just live with it. I mean, it's just something that you sometimes just have to live with to save your hair, because it does leave some kind of residue. But if you can talk to, like you get your dermatologist to talk to the pharmacist to give maybe a different vehicle, it may not be as bad. Okay, so changing the vehicle to something called VersaBase might make it less scaly or flaky.
Okay, so changing to something called VersaBase.
Yeah, that's
Okay.
something that a lot of people like.
Okay, great. Thank you. Is there any evidence to suggest LPP slows down once menopause passes or resolves? Dr. Donovan.
Not really. We don't really have that evidence. Certainly, lichen planopilaris is likely to start a little bit earlier than menopause in many patients. But we don't have any really great evidence that the menopausal transition is a key positive prognostic factor in this condition.
Okay, we still have lots of questions. Is hair transplant covered with immunosuppressive treatment during the initial period of triggering the inflammation? Dr. Shapiro.
Covered by insurance? I'm not sure what. Hair
Yeah, let's.
transplant is not covered ever by insurance. Okay, it's a cosmetic procedure, and no hair transplant surgeon, unless they do it for charity reasons, no hair transplant surgeon is going to do it. It's under insurance because the insurance pays so little, and it costs so much to do a hair transplant. All the people who are involved in it, the nurses, everything that. So there's a price for a hair transplant, and the insurance
Yeah,
never.
I wonder whether or not the question is actually referring to if there's an immunosuppressive drug you can take while you are having
Okay. Now I understand.
a
Okay.
transplant. No, I thought it was
Yeah,
the same
well,
thing too.
okay. Well, yeah. In Spain, they do it. They up the dose of Plaquenil. They up the dose of various things, and they do the transplant on these people. However, in our very litigious society, I think we have to be very careful, and I would avoid doing a hair transplant.
Okay, thank you. Dr. Shapiro, I was prescribed 7% minoxidil with 0.025 tretinoin and had immediate hair growth on my frontal hairline. Is this safe to use?
Yeah, it is safe to use, but I'm wondering how much you're paying for it because it's a compounded solution, 7% minoxidil, then adding tretinoin to it as well. Now, I would like to know if that person just used 5% minoxidil that you can get over the counter. Would that have worked just as well? I would like to know. They might have done well just with regular minoxidil rather than increasing the concentration by 2% and then adding tretinoin, which is supposed to kind of increase the absorption. That is so old, from 1986. There are papers using that. It was only proven once, really. Okay, and I question the stability of putting tretinoin and minoxidil in the same bottle. You have to make sure with the pharmacist that one is not degrading the other. Because the old adage from many years ago, when this was first introduced in 1986, we were told they should be separated and put minoxidil on separately and then tretinoin separately, because the tretinoin may affect the minoxidil, although that still has to be studied more. So I think it's a good idea I think it's safe, and if she's getting good results, keep on using it. But I wonder if 5% minoxidil alone would do the trick. I don't think tretinoin alone would do the trick.
Okay. All right, thanks. Okay, in this lightning round, next question to Dr. Donovan. Are sulfates in shampoo thought to be a contributing factor in FFA?
No.
Okay, thank you. Next question. What dose range in megahertz, I believe, do you use for eczema laser treatment in LLP? Dr. Shapiro.
Well, as I said, I refer everything out. We have a laser person in our department who I send to. I don't know what the initial energy levels should be. They know.
Okay.
But I can tell them you have to go at least twice a week. You should go twice a week for this to work.
Okay, thank you. Has gluten ever been implicated as a cause of FFA, Dr. Donovan?
Not yet.
Okay, but it may be coming, right? Maybe?
Well, we don't have any great evidence. I mean, in other autoimmune diseases like alopecia areata, which is one of the classic ones, maybe some weak evidence in children, but not much in adults. But, when you have one autoimmune disease, you are at risk for another one. And so we have to be open to the possibility always of celiac disease. It's a common condition in the population. but it's not something that we have good evidence for in FFA or LPP. And so a gluten-free diet without any good evidence of celiac disease in these two conditions, probably not worth it.
Okay, thanks. What's the difference in the hair follicles causing FFA to only attack the frontal hairline versus the rest of the head? Dr. Donovan, I'm going to give that one to you because that was what you covered.
Yeah, we certainly don't have all the answers yet. We really don't know. There are, different nerves that innervate the face. There are different types of hair follicles in this area. There's different sensitivity to androgens in this area. There's probably multiple reasons that come together to answer this question, and we do not have all the pieces of the puzzle lining up yet.
Same, but different, right?
Same, but
Okay, I use doxycycline and have for 7 years now. Every time I stop, my condition flares. At what point do I do what do I do next? Doctor has been hesitant to try something else. Dr. Shapiro.
Okay, the aim of therapy is to find the lowest dose that controls the problem. So if you're on, I wouldn't necessarily stop it, I would taper it and find out what the lowest dose. It might only be 50 milligrams every second day. I have no problem with somebody on that chronically, as long as you check their blood, make sure they're okay with their liver function tests and complete blood count. Once a year, if somebody's on doxycycline, we should do a blood test. But if they're on a low dose, I have no problem. So this question, she says, if I stop it, it flares. Well, don't stop it, taper it and see what the lowest maintenance dose is. That's medicine. That's what we do for everything.
Okay, thank you. Next question. Oh, my screen is just frozen.
I can read it. If FFA is an autoimmune disease, why can it become inactive? And the answer is, well, it's unpredictable. Okay, we don't know. Sometimes autoimmune conditions wax and wane. Okay, and so it can become inactive, even without treatment.
I think there's still a lot we don't know about autoimmune diseases per se. Okay, Dr. Donovan, if you don't use any medicine, will the hair on its own stop falling out? I think you've answered a version of this.
There are some patients that have, rapid flare, active disease, it quiets down and goes away. That's not the most common story seen in the clinic, but there are patients that do have that story. So I think that, if someone doesn't want to use medication, then, follow it closely. Is there evidence it's continuing? If it is, then explore the options with your physician.
Okay. If it's shown that one is very sensitive to steroids and doxy, is it reasonable to assume that other drugs tried should be with lower doses? Or what would be suggested for highly sensitive folks, Dr. Shapiro?
Well, it depends. I mean, I went through an algorithm. There are lots of choices, as Dr. Donovan pointed out. If you're allergic or sensitive to certain things, then you try something else along that, along the algorithmic approach. So you take that algorithm and you basically, if I'm sensitive to this and this, okay, they're out of the picture. Let's try something else then. And there are other things to use. There are things in our therapeutic cupboard that we can use.
Thank you. Does Plaquenil suppress the immune system, Dr. Donovan?
Very slightly. It's not a potent immunosuppressant like methotrexate, cyclosporin, but Plaquenil is a very weak immunosuppressant, and so there are some infections like herpes zoster that are slightly increased in patients on Plaquenil, but it's a very small risk, and so that teaches us that Plaquenil is a weak immunosuppressant, but it's not in the same category as some of the other more potent ones.
Okay, thank you. Next question. Does COVID vaccine trigger LPP inflammation, Dr. Shapiro?
We don't know. I always get asked that. When people have LPP, they call me, should I go for the vaccination? I say, go for the vaccination. We don't know whether it makes LPP worse. As far as I've never seen a case where it made LPP worse, but there may be cases out there. But as far as I know, it doesn't. And I certainly encourage my patients to get their vaccination.
Thank you. How often do you monitor your patients, Dr. Donovan?
Depends on how active they are. So someone who's incredibly stable and has been stable for 5 years, I might see them in 9 months or a year. Someone who's flaring and active and hair's coming out and they're red and itchy and they're sitting in front of me with an ice pack, I'm going to see them in 6 weeks or 4 weeks.
Okay, thank you. I expect the same as for you, Dr. Shapiro. If you
Yes,
stop
I
all
agree.
the treatment, which I did almost 10 years ago, will this disease turn into a more serious disease? Dr.
It's not
Shapiro.
active. If it's not active, it shouldn't. But I mean, it may reactivate itself for some reason. Okay, but no, it shouldn't become a more serious disease. But keep in mind, lichen planopilaris can cause other problems. It can cause ulcers in the mouth. I always ask whether they have anything in the mouth. I also ask if they have anything in the private area. It can cause ulcers there. And it can cause also nail changes. So when you talk about, well, can more serious things happen? Well, on the scalp, if they've been fine for 10 years, fine, but it could crop up in the mouth as an ulcer or in the genital area as an ulcer as well, or cause nail changes later on. So there are other things that it can present with.
Okay, thank you. Can I just ask a follow-up question to that? So lichen planopilaris, you mentioned, could show up in the private areas. Is that associated at all with lichen sclerosis, which is
Um, I've seen the two together, and I question the diagnosis of lichen sclerosis, whether it's lichen planus down there versus lichen sclerosis. Make sure the pathologist is absolutely certain that it's lichen sclerosis. But I've seen the two together, and there may be an association, but no one's ever really proven it.
okay? Thank you. If all the hair is gone along the hairline at least 2 inches back and there's no more flaking or itching, is the disease burned out or did it just run out of hair? Dr. Donovan.
So in frontal fibrosing alopecia, the hairline can certainly move back a lot more than 2 inches. And so for this particular patient, if the hairline is exactly the same in 2 years from now, then it probably burnt out and ran its course. But the hairline can move back all the way to the mid scalp, quite a long way, even towards the crown. And so in some patients, it never gets there, but in some patients, it does. So the fact that it's moved back 2 inches doesn't really sway me one way or the other that this might be inactive versus active. We need to follow it.
Okay, thank you. I developed prominent veins on each side of my forehead and a depression of frontal veins on my forehead and right temple. I was told this was another symptom of FFA, but I don't think I had that until I started topical clobetasol. Dr. Shapiro.
I think the veins can be part of FFA, but they can also be part of the treatment. They can be a result of injections of cortisone. Sometimes that can thin out the skin, even though you're not injecting right where the veins are, but it does
Yeah.
can spread. And also, clobetasol possibly can do it. I think more likely would be from the injections rather than topical clobetasol, but it can be from that as well. So when people have veins, I tell them, I don't know if this is from FFA. And sometimes they had these veins way before they had FFA, but they lost the hair, so now we see the veins. Okay.
Yeah.
And so, we just don't know whether it's FFA, whether they had it before, whether it's from the treatment
I've
we
got 'em.
gave. We don't know.
Okay, I know I've got them. I saw an article about adalimumab regrowing hair of patients with LPP. Do you know anything about this medication being used? I'm going to give that to Dr. Donovan.
Adalimumab, or these TNF inhibitors, have been studied and not very well studied. They can both cause and help many of these autoimmune hair loss conditions. And so the answer is we don't really know convincingly, but they can both help and hinder in these autoimmune conditions.
Okay, thank you. Any herbal remedies that help? Do B12 injections help? Dr. Donovan, I'm going to give that one to you.
I think B12 injections help a lot if you're low in B12. If you're not low in B12, it probably doesn't do much. Um, and so I think it's really important with vitamins and supplements that we really, think about our levels. Um, Patients may be low in vitamin D. This may be something that's worthwhile. Maybe low in iron, and that would be worthwhile if the levels are low. As far as herbal remedies, we don't really have a lot of great evidence yet. The things that are always talked about are the saw palmetto, ashwagandha, you name it. The evidence is poor, but the reality is that if someone wants to try these, then we follow if they're getting better, and if not, we abandon. And if they are getting better, then I may be open to continuing because we really are lacking a lot of evidence in these areas.
And presumably, if someone is taking some herbal medications or some vitamins, then this is something that they should share with their dermatologist, that they're doing this in combination with the treatment that the dermatologist is prescribing. Would you agree with that, Dr. Shapiro?
Yes, of course.
Yeah. Is there a future role for biologics to treat LPP, so the TNF, PDE4s, IL-17s, et cetera, et cetera? And I'm going to add and FFA to that question. Dr. Shapiro.
Well, there is a future. I think we need to do more studies. And, to do a study is not so easy. Everyone says, oh, let's try this and let's try that. But to get ethics review board approval, at least at NYU, takes a long time. And it may take, sometimes you have an idea, you may not get it approved by the ethics review board for at least a year, possibly even longer. But I think all those things may have some potential for helping this immunologically mediated condition.
Right. Dr. Donovan, do you have anything? I just want to check in with you on that.
Yeah, and I think they may have a role for sure. There's probably not one type of LPP. There's probably 8 or 13 types of LPP, and some of them are going to be sensitive or helped by these biologic agents, and others are not. And so I think that the answer is we need to keep thinking and studying, and there probably is a role for some of these in some patients.
Okay, thank you. Should we try tattooing or microblading around our hairline if we have FFA? That's actually an interesting question. Dr. Shapiro.
I'm always worried about Kevnerization, but I don't think it's going to be a problem. I think scalp micropigmentation is a good idea if you find someone who knows how to do it properly and can look natural. Okay, but if somebody has very active disease, I wouldn't go around to, using scalp micropigmentation while it was so active. If it's not active, let's try it out. Try it on a test area first. Make sure it doesn't flare up something, and then you can use it.
Yeah, I see Dr. Donovan nodding there. Okay, next question. If a biopsy shows fibrosis, does that mean scarring alopecia? Any other conditions that would cause fibrosis? Dr. Donovan.
It's such a great question and one of my favorite questions. The answer is no, that the scalp of human beings has some degree of fibrosis quite commonly. And that finding does not automatically cause one to hit the buzzer that this is lichen planopilaris. And so the normal scalp has fibrosis. Androgenetic alopecia, we know, has some loose fibrosis. And so the key is that one needs a pathologist who appreciates this question and can look at the other things that are found in scarring alopecia, like loss of sebaceous glands and other findings as well. More intense inflammation, more damage to the hair follicle, which we call necrosis or apoptosis or lichenoid change. And so I think that, whenever one has a biopsy, the key that the key is, where is the biopsy being shipped off to? And is it going to be read by someone who really enjoys reading scalp biopsies and is good at it? Because it is very much a skill to read scalp biopsies.
Wow. Okay, I wanted to state for the record that you guys are rock stars. You have answered so many questions that we are down to our last three. So, the next and or third last question: oral minoxidil versus topical minoxidil and FFA are both effective, or is one better than the other? And I'm going to pass that to Dr. Shapiro.
Well, I use a lot of oral minoxidil for androgenetic alopecia. I'm also using it for alopecia areata combined with tofacitinib. For scarring alopecias, I think there's a place for it because many of these people have androgenetic hair loss as well. So it may help thicken up the hairs that they actually have, but it won't necessarily stop the scarring process from progressing. So, but I think it's, I like oral minoxidil. I think there's maybe a place for it, but nobody's really studied it that well in scarring hair loss. Now, is it better than topical minoxidil? Nobody studied this in scarring hair loss. So it's still up in the air. If someone hates putting on this lotion, then give them the oral, I suppose. But I'm not sure that it really it does. I know for sure it does not stop the scarring process, but it may rescue any of the androgenetic process that they may have at the same time.
Okay, thank you. Dr. Donovan, I have an appointment in March to see you. Actually, sadly, I don't, but this person does. What should I be doing in the meantime to tame the disease?
So I think that it really depends on the individual's specific story. And I think that if there is a dermatologist that you're currently working with, or a family physician, there are things that can be done, especially if you're working with a dermatologist, including looking at if you're using topical steroids appropriately. Are you using the non-steroids appropriate, especially this ingredient tacrolimus and pimecrolimus, which goes by Elidil and is a cream. This can be used in FFA along the frontal hairline. We've spoken about some options which have relatively good safety, including the antihistamines, which can go a long way for some patients. But the long answer is it's hard to say for sure without a full understanding of the patient's story. If a patient's going to see me in March, for example, and they hope to have a baby next January, then the answer is that we will not be using finasteride. We will not be using probably many of the oral medications, including oral minoxidil. And so it really comes down to a case-by-case basis. If someone has severe depression and has been on antidepressants all their life, we have to be cautious with the anti-androgens. And so that's why really this question is challenging, because it depends on the patient's full story.
Okay, thank you. So our last question is going to go to you, Dr. Shapiro. How can this person see you if they cannot afford a private appointment and cannot go to NYU Clinic because they live in New Jersey?
Okay, for those who can't afford a private appointment, we do see patients at Bellevue. Bellevue is a hospital on First Avenue, and you can go through that. It's a resident clinic, though, so you'll be seen by a resident first, then you'll be seen by me. And I usually do that on Monday mornings. And so if people cannot afford, they can always go through the Bellevue Clinic.
Well, thank you very much, Dr. Donovan, Dr. Shapiro. As I said, you guys have been rock stars. Great answers. I think you have made a real difference in people's lives today. You've certainly answered a lot of my questions. So thank you. And I look forward to seeing you both in board meetings as we move forward. I want to say to everyone who's here on the call today that this September, is is, because it's committed to increase awareness, there is going to be National Scarring Alopecia Awareness Month, and that's launching for September 2021. You will be getting information about this in as long as you've registered and we've got your email address. You will be getting an email and information about this going forward. So we have gone about half an hour, actually 35 minutes overtime in this, and so I thank everyone thank Dr. Shapiro and Donovan for giving us all of this really great information.
Thank you very much.
And good
Thank
night,
you.
everyone.
Good night, everyone.